We are back with another episode of the Erectile Dysfunction Radio Podcast. Today we are joined by Dr. John Masterson. Dr. Masterson is a fourth-year urology resident at Cedars-Sinai in Los Angeles, California. He graduated from the University of Miami School of Medicine and is originally from Philadelphia. He joins us today to help us better understand what a priapism is, a phenomenon that is associated with erections and potentially with erectile dysfunction. Dr. Masterson, thank you very much for joining us.
Thank you for having me. I really appreciate the opportunity.
So before we get into priapism, can you just share with our listeners a little bit about urology residency? What type of patients do you see? What cases are you working with?
Sure, yeah. So like you said, I'm a fourth-year urology resident. Most residencies in urology are either 5 total years or 6 total years. Historically, they were usually 6, where you do 2 years of general surgery up front. Now that's kind of changed, where you do sort of 1 year of gen surg in the beginning. And then the remaining years are all urology, and the 6-year programs typically have a built-in research year. So you actually spend a year out of the hospital in the lab doing either basic science or clinical research. As residents, this is your opportunity to learn how to operate for the most part. So, you spend a lot of your time in the hospital doing surgeries with your attendings. It usually starts out your first couple of years doing mostly cystoscopic cases, which are usually endoscopic, bladder cancer related, or like transurethral resection of prostate for men that have BPH and things like that. A lot of kidney stones as well. And then as you sort of move up into your upper years, you do laparoscopic and robotic surgery, and sometimes open surgery as well for kidneys, bladders, prostates, usually a lot of cancer operations as well. And then also as a resident, you're seeing lots of consults in the ER, consults on the floor, some of which, especially at Cedars-Sinai, are priapism. So that's usually how we see those patients, is in the emergency room.
Okay, so let's use that as a segue and talk a little bit about what exactly is a priapism.
Yeah, so a priapism is basically it's like the feared outcome of, I guess, like if you ever see a commercial for Viagra, it'll say quickly at the end, if you have an erection lasting longer than 4 hours, contact your physician. That's a priapism. That's basically the thing that everyone's afraid of with erectile dysfunction medications. That's like the feared side effect or complication. And it's essentially an erection that lasts longer than is desired or is expected to. And the main concern is that, especially in the form of priapism called ischemic priapism, there can be permanent erectile damage. So if you have an ischemic priapism, you can have permanent erectile dysfunction afterwards.
Okay, so let's kind of dig into that for a moment. Now, physiologically, once a man achieves an orgasm, should the erection subside and should it return back to a flaccid state? And is a priapism specifically like noticeable or measured by a post-orgasm erection, or any erection with or without an orgasm that lasts beyond a certain period is problematic?
Yeah, so I guess physiologically, they're basically pro-erection and detumescence is what we call, like, when you have an erection that naturally goes away. It's detumescence is what that's called. So there's sort of this like two sides of the scale. There's like pro-erectile physiologic functions. This usually happens at the level of smooth muscle in the vessels of the penis, or the corpora, which are basically 2 big blood vessels. Those are the things that fill with blood and become hard. It's usually mediated by nitrous oxide. So if there's initial, sexual stimulation, these smooth muscles relax and allow blood flow, venous blood and when things are working properly, it's venous blood, to enter the penis. And then the sort of natural drainage mechanisms are compressed so that blood stays in the penis, and that's how you have a rigid erection. And then, so then after orgasm, or if there's a loss of stimulation, then you sort of switch over to the detumescence phase, and the detumescence processes where those smooth muscles will constrict, and that blood will then leave the penis. And as the penis becomes sort of more flaccid, those natural drainage mechanisms, these venules outside the corpora, open up again and allow the blood to leave the penis. The issue with priapism is that basically those pro-erectile pathways, that relaxing of the smooth muscle, sort of becomes paralyzed and it becomes stuck in that state. And it's sort of like the tipping of the scales gets stuck on the side of pro-erection, and that venous blood can't leave the penis.
Okay, and what I'm gathering from that is that the pro-erection side is also what contributes to the compressing of the release side. So as long as it's stuck with, in that erect state and it doesn't really kind of move out of that, there's no escape for that blood. Is that correct?
Correct. Yeah, there are some good diagrams of this online. I wish I had one to show, but basically the outer layer of the corpora cavernosa and the penis is this tough tissue called the tunica albuginea. And then even outside of that, there are these little veins or venules that it's sort of like a positive feedback loop. But like as the corpora expands, it compresses the escape mechanism for blood. So then that's how you stay in this rigid state. And then, with priapism, I guess sort of fundamentally priapism is any erection that lasts longer than desired. But specifically in ischemic priapism, even after orgasm, even after loss of stimulation, not only do you have a persistent erection, but you actually have pain, because with ischemic priapism, that deoxygenated venous blood gets sort of trapped in the penis, and the penis is basically holding its breath at that point, which is why we get concerned.
Yeah. And oxygen is just a vital ingredient in the life of the human body, and that includes the organs.
Absolutely.
So priapism is often discussed in the context of medications. Now, there are a number of medications that are in the PDE5 class. So I want to know if there's any difference between those different medications in terms of risk of priapism, and with other treatments for erectile dysfunction, like injections and whatnot. Does that increase the risk of priapism, decrease the risk, or does it not make a difference?
So to my knowledge, in terms of the oral medications like Viagra and Cialis, to my knowledge, there's no increased risk of priapism between the two oral medications, the two types of pills. So I guess sort of broadly, if we move up the ladder from least invasive to most invasive therapies for erectile dysfunction, usually Viagra, Cialis is where people start. Then you can sort of, if that doesn't work for you, you can sort of escalate to intraurethral suppositories that have vasodilator medications that go into the urethra. And then there's actually intracavernosal injection medications. It's usually called trimix or bimix. It's called that because it's a mix of either 2 or 3 medications that are usually vasodilatory. And those are the medications that carry a significant risk of priapism. We actually sometimes use those medications in the office to induce erection in men at a very low dose, because it's so potent, it'll work in pretty much anybody. It'll certainly work in anyone that does not have erectile dysfunction. But then in men with varying levels of erectile dysfunction, you have to sort of titrate the correct dose for them in the office. But those medications certainly carry a risk of priapism, particularly, especially because men are they're dosing, they're administering this themselves at home. It's not always
it's not always exact in terms of how much they put in the syringe or how much they get out of the syringe. There's
absolutely a risk of user error for sure. And no two vials are the same for every patient. The ratio of medications can be different. So if you draw up 5 mils of one person's trimix versus another, the ratio of the medications could be different. It could be different medication entirely.
Okay. Now, are there other medications that are not necessarily for sexual function at all that would increase the risk of priapism as a secondary or a tertiary effect?
Yeah, so there are medications that do carry warnings with priapism as a side effect of medications. Usually, some antipsychotics, some psych meds. Trazodone is one that we're classically taught in med school. I think the review book says to remember trazodone as trazobone because it can cause an unwanted erection. Um, so yeah, those are medications. Those are non-ED medications that can cause a priapism. And then there are some medical conditions as well. Sickle cell disease is one where people during sickle cell crisis could present with a priapism. We've seen that here. And even, just sort of the broad category of like also sort of related to sickle cell, hematologic disorders, like anything that basically polycythemia, anything that would make it hard for that blood to drain out of the penis.
Okay, so I was going to come to that question as if a priapism can occur naturally. So it sounds like what you're describing though is that there is an underlying medical issue that would cause that for a healthy man who has no underlying disease and is not using a medication. Is this the kind of, when you talk about this paralyzing of the process, is this the kind of systems glitch that could occur on anybody, or is this an indicator of either use of a medication or some kind of underlying disease?
It would be very unusual for there not to be some sort of underlying, like off baseline process, whether it's medication use or a hematologic disorder. There's also an entity called stuttering priapism, which is a priapism that kind of recurs and recurs. And, we have one patient in particular that has come back quite frequently to the emergency room with priapism that has had to get irrigated or treated in the ER by several of our residents, who has had a negative workup for everything. And we can't figure out why this guy keeps getting ischemic priapism over and over again. So he has a stuttering priapism. Yeah, so I guess to answer the question, it would be highly unusual. Yes.
Okay. So Dr. Masterson, what is the cutoff point at which an erection goes from really strong to really problematic? In other words, it sounds like you go from 0 to 0 at some unhealthy cutoff point. And we spoke about post-orgasm. Some men, will maintain an erection post-orgasm for a little bit of time, but for the most part, it should be dissipating. So what is that generally considered like the cutoff point where it's a problem?
So I think the sort of boilerplate for that you'll find on medications is 4 hours. You should be seeking help after, you should be calling someone at 4 hours. What we have found through our own research and other research, I have to give a quick shout out to one of my mentors in priapism. His name is Hansen Zhao. He was a chief resident here at Cedars 2 years ago. He really sort of started a lot of the priapism research here at Cedars. He's the one who kind of noticed that we had a lot of people coming in with this problem, and he created a nice database over about a 10-year period. People came into our hospital. It's almost 200 patients. And actually through that research found that at least among our series, at about 24 hours was a positive predictor of men needing to proceed to a more invasive therapy to treat their priapism. But I would say, more than anything, as soon as a patient starts experiencing pain, like whatever period of time it takes for there to be pain, that's when you need to seek help. And not everyone knows that. So they just try to like ride it out at home or take a cold shower, things like that. But that's really when the clock starts ticking in terms of future erectile function and future erectile health, is when you have pain, because pain equals ischemia.
Okay, so that's important to know. It's not necessarily, and the commercials do say, if it's lasted longer than 4 hours, consult your doctor or go to your emergency room. But you're saying that in reality, it's really a measure of pain. When you start to feel that pain, that's a clear indicator that there's something going wrong. Obviously, you shouldn't let it just go on in perpetuity. If you're not feeling pain, probably need to get checked out and get that addressed. But that's a much better measure than any specific time frame. Okay, so Dr. Masterson, how is priapism addressed? You've mentioned emergency room, which I'm sure is getting some of our listeners' anxiety spiked just hearing about this being addressed in the emergency room. You also said the word irrigation, which seems to indicate that somehow you're going to irrigate the blood out of the penis to get this to go away. So what exactly does this mean?
Yeah, so I guess sort of to back up just a little bit. So I had mentioned ischemic priapism. There is also non-ischemic priapism, which sort of meets the criteria for, unwanted erection over a certain period of time, but there's usually not pain. So that's kind of the first thing we, triage when patients walk through the door, when they have an erection that's lasted too long. If they're not having pain, it's probably what we would call high flow priapism or non-ischemic priapism, which is usually the result of like an arteriovenous fistula. So there's not actually that sort of like trapped venous blood in the penis. There is actually arterial oxygenated blood entering the penis. So that's sort of less of like an emergency. And some of those will resolve on their own. Some of them may need sort of more advanced imaging to identify that fistula. There's usually a history of trauma, some sort of straddle injury. And those would basically be treated with potentially with some sort of interventional radiology, vascular procedure to fix the whatever aberrant connection there is. For ischemic priapism, if someone's having pain, the first thing we do is, you want to get a history, see if they've used a medication, see if there's or if this is related to sickle cell. If it's sickle cell, treating their crisis may resolve the priapism on its own. But sort of regardless, all roads kind of lead to the same type of treatment, which is that, number one, you want to get a blood gas from the penis. You actually want to aspirate a sample of blood out of the corpora and send that to the lab so that they can measure the oxygen level and the pH and things like that to confirm your diagnosis. But truthfully, even without that, if a patient's having pain, they have an erection that's gone on too long, the first goal is to get that deoxygenated blood out of the penis. So that basically involves, after administering lidocaine, 18 gauge or large bore needles into the penis. There's a couple different ways of doing that. Some people go perpendicularly through the side, some others go through the glands, and getting that blood out. Some will also recommend irrigating with saline, but the other important aspect of this is using a medication called phenylephrine or neosynephrine. It's an alpha agonist medication. So when we talked earlier about the vasodilatory or vasodilation of the smooth muscles in the corpora, this basically helps constrict or contract those muscles to encourage drainage out of the penis.
Okay, so you're saying it's almost like a twofold approach. You're trying to get the body to naturally drain, but also taking blood out of the penis to kind of assist in that process as well.
Yeah, you're trying to like reverse the process, like you said, and get sort of tip the scales back in the favor of, anti-erection or detumescence, but also that blood just has to have somewhere to go and you have to just get it out.
Right.
And
there's no way to oxygenate the blood when it's in there. I know that many people get queasy at the idea of having, needles and blood draining out of the penis. Is there any way to treat the blood that's currently like locked in and deoxygenating inside of the penis? Can you reoxygenate it, or it needs to just come out?
Yeah, unfortunately, no. There's no way to do any like CPR for the penis. But this is getting a little bit in the weeds. But sort of down the line, one of the like later in the algorithm ways to treat priapism is to actually intentionally surgically create an arteriovenous fistula, like I had mentioned with the high flow priapism. And basically create that. So you sort of like reroute the like inflow and outflow of the corpora to allow oxygenated blood to get in and the deoxygenated blood to get out. But that's kind of like an end stage treatment.
Is that for more like the recurring situation where you would go in and try to do that
or for, if basically all of your emergency room efforts fail, that's something you could then proceed to the OR to do. But yeah, in the emergency room, that's basically where we do what we call like the irrigation of a priapism, where, you drain that blood out. you give phenylephrine, and you can do that for up to an hour. You have to monitor patients while you're doing this to make sure that they don't have elevated blood pressure or decreased heart rate, because if the phenylephrine gets taken up systemically, there can be systemic symptoms as well.
Got it. So this is definitely something that has to happen under medical care in an emergency room. This is not a DIY project by any stretch of the imagination. This needs to be done under, with full medical care.
Yeah, and interestingly, phenylephrine is a very similar, mechanistically, it's a very similar medication mechanism as Sudafed. So patients will sometimes take Sudafed at home if they realize they have an erection that's lasted too long, because it sort of acts in the same way. It's obviously not as strong or potent as delivering it directly to the corpora, but that's something that's part of the DIY solution for this, I guess.
Got it. Because certainly when that does not work, the rest has to be done in a medical setting with medical professionals. Now, what is the risk in delaying this? And this is really important because there are many men who do avoid. They avoid getting treatment for erectile dysfunction. They avoid getting all kinds of medical treatments, crossing their fingers and hoping that things self-resolve. So if a man is feeling that pain and, like you said, I'm just going to stick it out, I'm not going to rush, I don't want to make a scene out of everything. What risks does he run by not getting this treated or addressed in a timely fashion?
So basically, as you might imagine, this is something I think that neurosurgery people say, but time is tissue whenever there's an embolic stroke to the brain or something like that. So it's kind of the same with priapism. Time is tissue. And if you wait, you'll have permanent changes to your corpora where it'll basically become fibrotic. And basically the risk is permanent erectile dysfunction. And we find that, anybody who waits over 24 hours, the guidelines quote 36 hours, you can pretty much expect to have, severe erectile dysfunction for the rest of your life. And actually at 36 hours, some people would actually recommend not even really attempting to perform irrigation aspiration. You may actually just proceed to the OR and place a penile prosthesis at that point as an upfront treatment.
Okay, meaning it's at that point it's assumed that this person is not going to regain natural function at any point.
Yeah, and that's what's tough as well, because I mentioned irrigation in the operating room. Then the recommended way to treat priapism is sort of this escalating invasiveness of procedures. So if aspirating and irrigating through needles doesn't work, the next recommendation is to perform a shunting procedure, where you basically, if you were to do what's called a distal shunt or a T-shunt, you would basically bury the blade of a scalpel through the glands, the tip of the penis on either side where the corpora are, and just create larger outflow mechanisms for that deoxygenated blood. And then if those techniques don't work, you proceed to the OR and perform what's called a corporal tunneling procedure, where you basically take a large dilator or a sound, and you tunnel proximally along the length of the corpora. And then you sort of enter this territory of, the treatment is going to cause permanent erectile dysfunction, or could potentially cause permanent erectile dysfunction. So it's what's going to cause erectile dysfunction, the treatment or the disease? So it becomes this conversation with the patient about, look, we can try to stay as conservative as we can, with the understanding that if we proceed to more invasive procedures, you may end up with permanent ED either way.
How often is it, or what percentage of priapisms that show up in the ER end up in this advanced treatment situation?
So for us, in one of the studies we had published, I think it was about 12%. So, certainly the minority of patients, which is good, because we see most of our patients coming in before 24 hours, which is great. People have enough self-awareness. Uniquely, and not to just plug our own research here at Cedars, but what's sort of unique about the population we found at Cedars-Sinai is that about half of our patients, like half of almost 200 patients over a 10-year period who had a priapism in the ER, it was due to the use of those intracavernosal injectable medications like Trimix or Bimix. It was due to basically recreational use of those medications. So these are men that don't necessarily have erectile dysfunction. They are using medication that they got from a friend or a sexual partner, and they're kind of using it really just recreationally. So they are not the ones who got the counseling from their doctor and things like that. So
they're not properly dosed. I mean,
exactly.
Got it.
It's a super risky behavior, and that is, half the priapisms we see here at Cedars. So they tend to sort of come in closer to that 24-hour mark, which is a shame because a lot of them didn't have ED to begin with.
Yeah. For men, though, we want to encourage men to do what's obviously in their best health interest. We think addressing these things sooner rather than later is best. For a man who comes in at the 4, 5, 6 hour mark, isn't necessarily feeling a tremendous amount of pain, just starting to feel it. What are the percentage of men who, dealing with it up front, will end up in one of these much more advanced kind of situations where these other methods, for whatever reason it might be, have failed?
Yeah. I mean, I don't have statistics to quote you. But, if you're within that sort of, 4 to 6 hour, really less than 24-hour time frame, you should feel pretty confident that, first line intervention, should work. You really should not have any, permanent erectile dysfunction after that.
Meaning the earlier you seek help, like you said before, time is tissue. The earlier you seek help with this, the better the outcomes are going to be, statistically speaking.
Exactly. And, like I mentioned before, the way, in the same way that, pain is when the clock starts ticking, I think relief of pain, in the process of, draining, the deoxygenated blood and things like that, relief of pain sort of resets the clock. So, that's something I think we've done with patients is basically say, hey, look, like, I know this is torture, but if we can just sort of like get some oxygen back to your penis, even if we have to like do this again 24 hours from now, that's better than us taking you to the OR and tunneling your corpora and, having our intervention, cause erectile dysfunction. So you can also check people with repeat blood gases and things like that. And you can actually just measure the oxygenation of their penis. So you can reassure yourself and the patient that way.
Yeah. Now, millions and millions and millions of men have and continue to take PDE5 inhibitors.
Mm-hmm.
What is the, what's the risk? How common is a priapism with appropriate dosage and use of a PDE5 inhibitor? Is this something men should be worried or concerned about, generally speaking, or should they be able to use these medications comfortably?
I mean, it's certainly something they should know about, but the risk is low. It's certainly not nearly what it is with intracavernosal injectable medications. With these Trimix, Bimix medications, the companies actually have like those patients are better educated because it's like so much more of a risk factor. And they actually, I believe in the medication inserts, they have the sort of like telltale signs of a priapism, and they recommend, take a Sudafed, put ice on it, things like that, things that could sort of remedy at home or buy you more time. But I think for men who are on oral medication, the risk is low. It's not something that should be like keeping you up at night or stopping you from taking the medication.
Now, in your research, maybe you've come across this, or maybe there's just more general data, but I'm wondering, are there men who are just biologically or organically more prone to priapism than other men, or is it really, as far as we can tell at this point, more of a random phenomenon?
I think, I think if I were to say that men like had any sort of genetic predisposition, it would sort of go hand in hand with whatever underlying pathology they have. Again, I think, the non-medication induced priapism is rare, and you usually would see it in a patient with a hematologic disorder. We've certainly had a few patients that came in, claim they never used any medication, and have had a negative hematologic workup and just sort of have this like unexplained priapism. They may have just sort of like a faulty, venous drainage mechanism, or they may have some underlying, neurotransmitter disorder that sort of favors the erection state more than the detumescent state. But yeah, those people are hard to identify. And priapism in general is a tough condition to study because it happens so sort of randomly and sporadically. Mm-hmm. And it's so associated with medication that anyone we see in the ER who claims to not have used a medication, we like don't believe them, and we ask them again and again, and sometimes they'll finally admit to it.
Got it. Now, is there any connection between priapism and erectile dysfunction? I want to be particular about this. Obviously, a lot of these men are coming in because they are using erectile dysfunction medication. So clearly there is some connection. But is there, have you seen a phenomenon where men who have experienced a priapism will then develop a severity in their erectile dysfunction as a result? In other words, does this induce some kind of fear in men to like re-engage in sexual activity, or to even intentionally or willfully try to get an erection?
I see. So more sort of like a psychogenic ED after like a priapism experience. Yeah, that's not something we've looked at. One of the like many priapism projects we did was long-term follow-up for those men who had a priapism using recreational intracavernosal injectable medications. And most of those men, broadly did not have, permanent ED and did not have like terribly worsening ED afterwards. And very few mentioned, psychogenic ED afterwards. I can certainly imagine that would be the case. I can see why that would happen, especially in patients who, had a priapism and were not using medications, and this just kind of like happened. That's certainly understandable. But yeah, I can't say for certain there's like a statistic on, how many men develop psychogenic ED after priapism.
Yeah, it'd be a very hard thing to document well, because again, most of these men, not the ones who are recreational users, but most of the men who had it before. So it becomes really difficult to kind of tease all of that out. But I could imagine that being a very just traumatic event, like having to go into an ER and get trained. I assume that there's no general anesthesia for this. So
there's no general. We do use local. We try to numb them up the best we can, unfortunately,
So you have to be witness to your own irrigation, largely. Yes. Which is
and I'll tell you, that's why as a resident, it is like it's one of the things that like young residents like dread. Because it is an emergency, but more so it's because the patient is like awake the whole time, and like you're kind of torturing them and you feel awful about it, but you also understand that like this kind of has to be done.
Any other important pieces that you have found in the research or in the clinical applications of priapism that you think would be helpful for our listeners to know about?
Yeah, I think the main thing, this is not like earth-shattering, but it's kind of just like listen to your doctor, follow the medical advice, follow the directions on like the Viagra bottle and like the Trimix. If you have a painful erection, seek help. It's not worth it. You only get one penis unless you want to have like a new one made later on. But yeah, don't mess around with it. As soon as you feel pain, that's when it's time to seek help, certainly.
Yeah, and it sounds like, again, if men are going to handle these situations responsibly, not delay, go in for treatment early, then it really is something that, even if it were to occur, is something they don't really need to be worrying about or ruminating. They should be able to, have enjoyable sexual encounters without having to worry about this phenomenon, and to just know that if it were to occur, that seeking help earlier and sooner is going to, in all likelihood, lead to outcomes where there is no long-lasting damage or effects, and they will be able to, re-engage and re-enjoy a satisfying sex life shortly.
Yeah, absolutely. Everything you said is absolutely accurate. Yeah, like it's it'll seem traumatic in the moment. That's just because, that's the nature of the treatment. But yeah, it's, if you seek help quickly, there's no really long-term deleterious effects, which is great.
Okay. That's really, really great to hear. I'm sure our listeners are going to feel relieved to know that, those long-term effects really can be staved off in almost all cases by just acting quickly. Dr. Masterson, thank you so much for joining us. We want to wish you best of luck on your continued journey through your residency. Look forward to the next generation of urologists coming to help us and educate us. So look forward to getting this episode out to our listeners.
Great. Thank you for having me. I really appreciate the opportunity.